Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins Professor of Cardiology, Hugh Hopkins, will be speaking about what is atrial fibrillation. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note, if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Hugh Hopkins to begin our presentation.
Great. Well, thank you very much. It's a great pleasure to be here with you to talk about atrial fibrillation. By way of background, I've been here on the faculty at Hopkins for 30 years. I direct the arrhythmia service, and one of my main focuses is atrial fibrillation. I see about 2,000 patients a year in the outpatient center and perform about 400 procedures. And I feel very comfortable speaking on this topic. So what we're going to do over the next 30 minutes is we'll provide a brief overview of Afib, why it's important. I'm going to cover the issue of stroke risk and anticoagulation, rate-controlled antiarrhythmic drugs, catheter ablation, risk factor modification, and then draw things to conclusion, all in 30 minutes. So it's a fairly large agenda. Here's my disclosures. So first, let's start with what is atrial fibrillation? Well, atrial fibrillation is a very rapid, chaotic upper chamber rhythm of the heart. The upper chamber, the atria, beat over 300 beats a minute, closer to 500 or 600 beats a minute. The lower chamber also beats rapidly, but the lower chamber's rate is determined by how many of the upper chamber beats get down to the lower chamber beat. So your pulse, even if you're in Afib, won't be 600 or 700, which isn't consistent with life, but it will be somewhere between 80 and 160 or 170. To make the diagnosis of atrial fibrillation, you have to have it shown, documented by an EKG or a monitoring device, and there's a number of these that are available. We can suspect atrial fibrillation in someone who has a jumping or irregular heartbeat that's sort of jumping all over the place. And some people describe it as a fish flopping in the heart. This just shows a schematic showing a normal heart and a normal heart rhythm. On the left side of the screen, you have your sinus node that triggers the impulse to go through the upper chamber, the atria. Then there's the AV node that filters the impulse and brings it down to the lower chamber through these right wires, these bundled branches. And this is a normal sinus rhythm. You have what's called a P wave and a QRS wave, and the heart rhythm is very regular. When you're in atrial fibrillation, the upper chamber has these constant multiple reentrant circuits, basically total chaos in the upper chamber, with the upper chamber beating 600 beats a minute. The rate of the lower chamber depends on how many of those beats are filtered out through the AV node. So here's an EKG of someone with atrial fibrillation. You can see that there's no P waves. Instead, you have these rapid undulations of what's called the atrium. That's the small deflections. And the big deflections are the ventricular rhythm. And you can see that the heart rhythm is irregular, which is the term we use to describe someone's pulse when they have atrial fibrillation. Now, how do we diagnose atrial fibrillation? Well, it usually starts with symptoms which trigger a visit to the hospital or to your physician. Afib can also be diagnosed on a routine office visit. It's not uncommon for someone to go into their internist feeling well, and their internist checks their pulse or listens to their heart, picks up an irregular rhythm, gets an EKG, and you leave with a diagnosis of atrial fibrillation. Another common scenario is patients getting a colonoscopy. Patients over 50, they're getting a colonoscopy. They show up, they have an irregular pulse, they get an EKG, and they're told they have atrial fibrillation. And for many patients, that's the first way it's picked up. The symptoms of atrial fibrillation vary considerably. They include palpitations, lightheadedness, passing out, chest discomfort, shortness of breath, decreased exercise tolerance, fatigue, decreased mental function, and then some patients are asymptomatic. The most common symptom of atrial fibrillation is actually fatigue, and it's not uncommon to have atrial fibrillation and to have absolutely no symptoms. This is just some material put out by the Heart Rhythm Society. AFib feels like drums pounding in my chest, thunder rumbling in my chest, fish flopping in my chest. It's just this irregular, quivering, irregular heart rhythm that's going on. If you check your pulse, normally you'd have a regular rhythm, with 60 beats a minute or 70 beats a minute. When you're in atrial fibrillation, it's jumping all over the place. The pulses vary in timing and also intensity. A more modern way to diagnose atrial fibrillation is with something called the Alive Cor monitor system, a cardia system. This is something you can buy on Amazon for about $60, $70. Turns your cell phone into an EKG machine, and you can just hold your finger on the recording device and you'll get your own EKG, and that will pop up whether it's atrial fibrillation or not. So increasingly, with more and more Apple Watches and the Alive Cor monitors, more and more patients are showing up to see me because they've self-diagnosed atrial fibrillation with one of these devices. This is just obviously the Apple Watch, which also provides this capability. Well, AFib is an important arrhythmia, and I'm glad they chose this topic for many reasons. First, it's unbelievably common. It's the most common sustained arrhythmia, affects 5 million Americans, and with the aging population by 2015, it's estimated that the prevalence of AFib will increase to 12 million Americans, mainly affects men and the elderly. And if you think of anyone who's 40 years of age, there's about a 1 in 4 chance they'll get AFib at some point in their life. AFib is also important because it's associated with an increased risk of stroke. Overall, if you have AFib, your stroke risk goes up 5-fold. Many strokes are attributable to AFib, and when you have a stroke from AFib, it tends to be a large stroke where you can't talk, you can't walk, you're paralyzed, and it's life-changing or life-ending. Atrial fibrillation is important because it fills up our hospitals. This is a study done showing the reasons why patients are brought into the hospital, and AFib, again, leads the way. AFib is also important because it increases mortality. We don't generally think of AFib as a life-threatening arrhythmia like ventricular tachycardia or ventricular fibrillation. But if you do a big study in patients with AFib and those without AFib, those that don't have AFib live longer than those who do have atrial fibrillation, even after you correct for other factors that may influence life expectancy, like hypertension, obesity, and so forth. AFib is also closely linked to heart failure. The worse heart failure you have, the more likely you are to have AFib. And also the patients with AFib are more likely to develop heart failure. This is just a number of heart failure studies making the point that the worse your heart failure, the more likely you are to have atrial fibrillation. Now, atrial fibrillation is also associated with a dementia. This is a study that was done comparing patients with and without AFib in terms of the incidence of dementia. The patients with AFib are shown in the open bars, and the ones without atrial fibrillation are shown in the dark bars. And whether it's nonspecific dementia, Alzheimer's disease, senile dementia, or vascular dementia, you can see it's more than twofold increased risk if you have atrial fibrillation. And I think increasingly a lot of people are drawing attention to this because none of us obviously wants to develop dementia. And finally, AFib reduces quality of life. This is a study that was done comparing AFib patients shown in light blue with patients with heart failure shown in this purple-pink color and normal patients in green. And you can see if you look at the AFib patients, they're much like the heart failure patients. Their physical functioning, vitality, general health, mental health, emotional role, and social functionings all reduce much like a heart failure patient and quite different than the healthy population shown in green. Now, this is a beautiful figure from the European AFib guidelines that were published recently, just summarizing the information I talked about. AFib is important because it increases mortality by 1.3 to 3.5 fold. It increases the risk of stroke. It increases the chance of heart failure. Cognitive decline goes up 1.4 to 1.6 fold. Depression is more common, impaired quality of life, hospitalizations. So there's obviously many reasons why no one wants to have atrial fibrillation. Now let's move on to risk factors for AFib. So the most important risk factor is increasing age. AFib is a disease that's rare before 50, then starts to shoot up. And by the time you're 80, 1 in 10 people have AFib. It's more common in men than women, more common if you're obese than if you're slender, more common if you have sleep apnea than if you don't, more common if you have hypertension than if you don't, more common if you have coronary artery disease, heart failure, hyper or hypothyroidism. AFib is also related to tall height and large body mass. The bigger you are, the more likely you are to have AFib. And if you think about it, whales are in AFib all the time and mice never get AFib. And that's also that same pattern is seen in patients. Small people generally fare better than big people in the terms of AFib. Family history of AFib at a young age can be an important risk factor. If you have siblings or parents who got AFib when they're 40 or 30 or 45, that's an important risk factor for you. You must have something running in the family that increases the chance you'll get AFib. There's been a lot of new data on the link between alcohol and AFib. We've known for a long time that if you get wildly intoxicated on New Year's Eve, you're likely to land in the emergency room with AFib. But we now know that even one glass of wine or one beer can increase the chance of AFib the following day or two. So any amount of AFib increases, any amount of alcohol increases AFib risk. Other risk factors include poor sleep and stress. This is just a schematic showing the mechanisms of atrial fibrillation. If this is the back of the heart, these are what's called the pulmonary veins that bring blood from your lungs to your heart. Most triggers for AFib, shown by these little stars, are in the pulmonary veins. You then have reentrant circuits. The yellow things in this slide are the autonomic ganglia. They're nerve bundles outside the atrium that play a role. But suffice it to say that the mechanism of AFib is complex and not fully understood. So now we'll move on to AFib treatment. When you think about treatment, we think about the guidelines. I was lucky to be a member of the writing group of the 2019 AFib guidelines, so I'm very comfortable discussing these with you. So when you think of AFib, I think of a four-legged stool. It starts with making the diagnosis. Once you make the diagnosis, you have to decide what the person's stroke risk is and whether they need a blood thinner. You have to think about rate control. You don't want the AFib to drive their heart at too rapid of a rate. You want to think about rhythm control. Should you get the patient back to sinus rhythm and how? And then we always think about risk factor modification. This is a chance to look at yourself in the mirror. If you're overweight, lose some weight. If you have high blood pressure, get it controlled. If you're drinking too much alcohol, cut it down. So let me talk a little bit about stroke prevention. When we think about stroke risk, we think about something called the CHADS-VASc risk score. And that's shown here, and you get a point for each of these risk factors for stroke: heart failure, hypertension, age over 75, diabetes, prior stroke, peripheral vascular disease, age between 65 and 74, and female gender. And then based on that, you come up with a scoring system. And in general, if your score is 2 or higher if you're a man, or 3 or higher if you're a woman, that would be a definite reason to be on a blood thinner. So current guidelines say if your CHADS-VASc score is 2 or more if you're a man, you should be anticoagulated. If it's 1, you should think about it. And if it's 0, you don't need to be anticoagulated unless you're going to do what's called a cardioversion, a shock treatment, where you get shocked back to normal rhythm. Speaking of cardioversion, this is what a cardioversion looks like. I'm not sure if any of you have AFib or have had a cardioversion. Fortunately, you're put to sleep when you have this procedure done, so you don't feel any discomfort, but it's a shock delivered to your chest to restore sinus rhythm. And when you do this, you have to either be on AFib for less than 48 hours, or you have to be on a blood thinner for 3 weeks, or gets what's called the TEE to make sure there's no blood clots in your heart, because the risk of a stroke when you do the cardioversion jumps up for a day or two surrounding that intervention. terms of blood thinners, you have lots of different options. You have warfarin, Coumadin, which is the old time blood thinner that's been around since the 60s. Very inexpensive, very effective, very inconvenient. You got to check your INR level. It's impacted by what you eat in your diet. It's hard to control. It takes a long time to build up, and it takes a long time to wash out. But fortunately, we have the new anticoagulants, the drugs, including the direct thrombin inhibitors, which are dabigatran, or also known as Pradaxa. And you have the factor Xa inhibitors, rivaroxaban, apixaban, and edoxaban. So there's a number of very good options. The new anticoagulants, the direct thrombin inhibitors and factor Xa inhibitors, act much more quickly. They stop much more quickly. They're more effective. They're more convenient. Their only disadvantage is they're more expensive. Now, when you can't take a blood thinner because you're having bleeding or you're falling or for lifestyle reasons, you don't want to be on a blood thinner, another option is to get rid of what's called the left atrial appendage. So this is a schematic of the heart. This is what's called the appendage, this little windsock. And this is the appendage shown here. And this is the appendage shown here. But this is an appendage with a clot in it. This is where most clots form in the left atrium that cause strokes. So one way to lower stroke risk is to tie this off, cut this off, occlude this appendage, and we have a number of devices to achieve that. And those include the Watchman device, which is a plug which you put in the appendage that's approved by the FDA about 6 years ago. The AtriClip's a surgical device you put over the appendage. The lariat's a newer catheter-based procedure that you can use to tie off the appendage. And increasingly, these options are used more and more, particularly the Watchman device. This just shows a schematic of the Watchman device going in, this plug. It goes into the appendage. You then unhook your delivery system. The tissue heals over, and then you don't have to take anticoagulants. So this is a very good option for many people. So moving on to rate control, keeping your heart rate from going too fast, because if it goes too fast for too long, you'll develop heart failure. So the goal is that you want your heart rate at rest to be 80 beats a minute or less. And you accomplish this with medicines like beta blockers or calcium channel blockers. And in the old days, we used a medicine called digoxin, but that's used much less commonly today. Another option is to put in a pacemaker and do what's called an ablation of the AV node, where you sever the connection from the upper to lower chamber. And we generally only do this in more elderly patients because this renders a patient pacemaker dependent, and we're eliminating a part of what we were all born with, which is the AV node, and we hate to be destructive as an electrophysiologist. This is just a schematic of a pacemaker put in your chest with the wires in your heart, and you ablate the AV node so the upper chamber can go crazy and your lower chamber's controlled by the pacemaker. And for patients who need this procedure, it can make them feel dramatically improved. It's been around for a long time and very reliable. Now we're going to move on to rhythm control. Should we get a patient back to sinus rhythm? And if so, how? So let's talk first about rhythm control and antiarrhythmic medications. So if someone's in continuous AFib, the only way to get them back to normal rhythm is to do a cardioversion. Now, if you do the cardioversion, the AFib will undoubtedly come back again. So usually you also put a patient on an antiarrhythmic medication to prevent the AFib from coming back. And if one medicine doesn't work, then we try another one. It's a little bit of a trial and error approach. The medications I tend to reach for first are medicines like propafenone or flecainide. They're first-line medicines. You can start them as an outpatient. You can't take them if you've had a heart attack, have heart failure, or have coronary artery disease. Another option is sotalol or dofetilide. Very good medications, but they oftentimes have to be started in the hospital. With dofetilide, you have to spend 3 days in the hospital when you start it because you may have a reaction. The FDA requires this. Sotalol, we have a little bit more flexibility about whether we start it as an outpatient or in the hospital. These medications can be used even if you have heart failure or coronary disease or a prior bypass surgery, for example. Now, amiodarone is our strongest medication. It's considered a second-line medication because it can affect your liver, lungs, and thyroid. So it's very commonly used. It's very effective, but it also have a lot of side effects when you're on it. You have to get annual testing of your liver, lungs, and thyroid to make sure you're not getting a side effect. And if you are, then you would immediately stop this medication. But for the right patient, it's a very good option. So now I'm going to move on to catheter ablation. That's the procedure that I perform to get rid of AFib with a procedure. This is just a picture of an EP lab. Here's the patient. Here's our computerized imaging system and CT scans. Here's the X-ray system, and here I am performing the procedure. This just shows the catheter going up from the legs into the heart where we perform the ablation procedure. Now, the way we do AFib ablation is we focus on these veins. I talked about these earlier, the veins that bring blood from your lungs to your heart. That's where AFib comes from. And that was discovered in 1998 by a group in Bordeaux, France. And this has set the cornerstone of the most important component of AFib ablation, is to electrically isolate those veins, to put a wall or a barrier, an electrical barrier around those veins. So this can be done with a number of different catheter systems, what's called radiofrequency ablation, shown here, where we put a roadblock, draw a circle around these veins to prevent the electrical impulses from getting out. This just shows this in real life. This is a CT scan done the day of the procedure. The red dots are where we burn a string of pearls, and this kills the tissue around the veins, so the impulses can't get from inside the veins where they start and they go crazy to the atrium to trigger atrial fibrillation. This can be done with RF, with heat, or with the freezing system, the cryoballoon system. And so there's a number of different options which your physician can discuss with you. Now, how well does it work? In an optimal candidate, success rate for one procedure, somewhere between 60 and 80%. If you're a poor candidate, it drops to 30 to 50%. Who is a good candidate? If you have intermittent AFib, you're a good candidate. If you're otherwise healthy, you're a good candidate. Who's a poor candidate? If you're 500 pounds, have been in AFib for 10 years and have a big left atrium, then you're a very poor candidate for the procedure. In general, we like to treat AFib as early as possible, because the longer you're in AFib and the more AFib you have, the more scarring occurs in your heart and the harder it is to get you back to normal rhythm. With multiple procedures, success rates go up. And when we talk about success rate, this is at 12 months follow-up. If you look at people doing well at 12 months, AFib will occur at about 5 years later in about 25%. So we never say we've cured AFib. It's AFib is in remission. It's controlled. It's like cancer in remission. We do a procedure, put you in AFib for remission, hopefully for a lifetime, but not always for a lifetime. So there's always risk to any kind of procedure. And with AFib ablation, the safety has improved dramatically since I've been performing this procedure for 20 years. And now the complication rate's about 1%. The various types of complications are shown here. Most you recover from, some you don't. So it's important to keep that in mind when you think about whether to have an ablation procedure or not. So what are the indications? If you have symptomatic AFib and medications haven't worked, that would be a clear reason to get an ablation. If you have symptomatic AFib and you don't want to take medications, that's a good reason to have an ablation. Or if you have no symptoms and you decide you don't want to live a life in AFib with the associated increased risk of dementia, heart failure, stroke, and so forth, that would also be a reason to think about having an AFib ablation to control the AFib, particularly if it's continuous and if medications can't get you back to sinus rhythm. So what's my approach for me? Most patients, I consider AF ablation a second-line option. I usually try drugs first. The first exception is if you have something called tachybrady syndrome. You have AFib, and when the AFib stops, you have very, very slow heart rhythm. That'd be a situation where we either put in a pacemaker, use medications, or do a procedure that gets rid of both the AFib and the slow heart rhythm. Also, elite athletes, most athletes don't want to be on antiarrhythmic drugs. Most want to go straight to ablation. And then there's other patients that just prefer to go and have a procedure right off the bat. There's been a number of studies showing that a catheter ablation is more effective than antiarrhythmic drugs. It's just a different type of undertaking. In terms of learning more about AFib, we put together the consensus document on AFib ablation. It's a great document. It's available on the internet that you can learn anything you ever wanted to know about AFib and more from this document. I'm going to skip this. One study you may have heard about in the newspaper is something called an study. This is a study published recently in the New England Journal of Medicine, where they took patients with recent onset AFib and randomized them to treatment with medicines or procedures, or just ignoring the AFib and rate control, and they followed them in terms of how they did. This just shows the two groups. There were about 1,400 patients in each group. Ones randomized to drugs were treated with drugs, and some 8% with ablation. In the other arm, AFib was basically not treated. So what happened over time, the patients that had rhythm control, where they tried to control the AFib with medicines and procedures, had a lower risk of cardiovascular death, stroke, heart failure, hospitalization, or acute coronary syndrome. It sort of pointed to the value of being in sinus rhythm. So this is an important consideration in our AFib patients. Finally, let me just touch on risk factor modification. It's very important to note that AFib is linked to weight. If you take sheep in the center of the smorgasbord, they get fat, they get AFib. If they lose the weight, the AFib goes away. Well, the same is true for patients. If someone's overweight and they have AFib and you get rid of the weight, the AFib is responds more easily to medicines, procedures, and in some patients, all you need to do is get the weight off. If you have sleep apnea, if you store, you may have sleep apnea. Treating the sleep apnea can make the AFib easier to treat. If you drink too much alcohol, you obviously should cut that back. Just a few comments on the obesity epidemic. I think we're all familiar with this. It's easy to talk about, it's hard to do, but when it comes to AFib, it's very important. Sleep apnea is also linked to AFib. If you have sleep apnea, it's important to get your sleep apnea treated. That will make your AFib easier to treat. So let me just conclude with a few take-home messages. AFib is common. Risk factors include age, obesity, family history, also male gender, body size. AFib increases the risk of stroke 5-fold. It also increases the risk of heart failure, dementia, and shortens your life. Patients with AFib and an elevated stroke risk should be on blood thinners or get the Watchman device. We treat AFib with medicines and procedures to improve quality of life. We may also make people live longer, prevent dementia, lower risk of heart failure, and so forth. But all of those extra benefits haven't been definitively proven as of this point. But we have increasing data suggesting that getting someone back to normal rhythm will reduce these risks of bad things happening down the road. So I'll stop there, and I think we're about on time, and happy to take any questions any of you may have. And I apologize again on covering lots of material in a very short period of time, but I wanted to get you as much information as possible to be helpful.
Thank you, Dr. Hopkins. The first question from our attendees is, does AFib get worse over time?
The answer to that is yes. AFib is age-related, and as you get older, AFib gets worse in pretty much everybody. The rate at which it gets worse is highly variable. And someone who has intermittent AFib once or twice a year, it may stay pretty stable for 3, 4, 5 years. On the other hand, one morning you can wake up and you can be stuck in AFib all the time and need to get a cardioversion. So the rate of progression is highly variable, but it absolutely is progressive over time because, God willing, we all keep getting older, and age is the most potent risk factor for AFib. Let me also add that the longer you're in AFib continuously, the harder it is to treat AFib. So if someone's been in AFib for 3 years or longer, where you've been in AFib for 3 years straight, it's going to be very hard to get you back to normal rhythm. Where if you come to your physician, you've been in AFib for 2 weeks, 2 months, or 2 days, it's going to be a much better chance that you'll be able to get that AFib under control.
The next question is AFib common after transcatheter aortic valve replacement?
Yes. So TAVR is a way to replace the valve without surgery. And if you think about patients who get a TAVR procedure, they're generally the very elderly patients, and elderly patients get AFib. We talked about of 80-year-old patients, 1 in 10 have AFib. And of patients that have aortic stenosis, it's far higher than that. So I would estimate probably 30 to 50% of patients who get a TAVR procedure also develop atrial fibrillation at about that time or soon thereafter.
The next question, does metoprolol ER last 24 hours? The patient or participant asked when they started a 50 milligram in the morning, they seem to intermittently get slight AFibs 22 hours after taking.
Yeah, I mean, the sustained release preparation of toprol is supposed to last a full 24 hours, but the dose level in your body can vary. It generally is higher early on and then tapers off. In your case, an easy solution would be to take 25 milligrams of the sustained release twice a day, and that would smooth out the level throughout the day.
Maybe the next question, is there any correlation slash causal relationship between left bundle branch block and AFib?
The only relationship between, I mean, both of those are, I mean, AFib is a very common condition, as we told you, 25% of everyone that's 40 or older will get AFib. Left bundle is less common. I would say left bundle might be 1% of people over time will develop atrial fibrillation. So left bundle is very common, but again, they're both age-related conditions. And so many patients with AFib have a left bundle and many left bundle patients have AFib, but not everyone with AFib is left bundle or vice versa.
The next question is, should you go to the hospital when in AFib?
That's a very good question. The answer is AFib is generally best treated as an outpatient. The reason to go to the hospital is if you feel like you're about to die. I mean, if you have AFib and your blood pressure is very low and you feel like you're going to pass out or you have terrible chest pain or something seems terribly wrong, well, then you call 911 and you go to the emergency room. If on the other hand, and then many patients, the first time they have AFib, they're not sure what it is. They don't know what to do about it. They may not have a physician. They commonly may go to an urgent care center or to the emergency room. But once you're an established AFib patient, the goal really should be to become educated to treat, so you're able to avoid the emergency room, because most trips to the emergency room are frustrating. You sit there for 6 or 8 hours, and it's not a exciting experience. And our emergency rooms are clogged up right now with the patients with other problems. So if you're an established AFib patient, you should learn as much you can about AFib, understand that it's not life-threatening in the short term. There's no big urgency to get you back to normal rhythm. The issue are, if you should be on a blood thinner, are you? If your AFib is going too fast, there's various medicines your doctors can give you, or they can tell you if you get an AFib, take an extra toprol, take an extra dose of diltiazem, relax, don't exercise. And then if it doesn't stop in 2-3 days, let me know and we can set you up for a cardioversion as an outpatient. So I generally really discourage my AFib patients from using the emergency room, certainly once the diagnosis has been made, unless they really feel terrible.
Next question is, for patients who are AFib free following ablation, when should they consider the Watchman device instead of anticoagulants?
Okay, that's a very good question, but different than the one I thought you'd ask. The first question, which most people ask, are, you have an AFib ablation, the AFib is gone, when can you stop the blood thinners? Because the AFib's gone, that's obvious. And the answer to that question is everyone who has an AFib ablation should be on a blood thinner for at least 3 weeks before the procedure and 4 weeks after the procedure, or 8 weeks after the procedure. And at 8 weeks, the decision about whether to stop the blood thinner or not is based on your stroke risk profile. So if you're young and healthy and have none of those risk factors we talked about, you can stop the blood thinner at 8 weeks. If on the other hand, you're 75 and have diabetes and hypertension and heart failure, the recommendations would not be to stop the blood thinner. Even though the AFib is apparently eliminated, your stroke risk is not reduced to normal. It's still elevated because you have a history of AFib. And then it's important to know that AFib can return after an AFib ablation. If it returns, it could be asymptomatic and it's occurred when you're sleeping and so forth. So current guidelines say if your CHA2DS2-VASc score is 2 or more, regardless of whether the procedure works or not, you should stay on the blood thinner indefinitely. Now, if you say you don't want to be on blood thinners indefinitely, you're falling, you're bleeding, you have nosebleeds, GI bleeds, urinary bleeds, or whatever, in that case, the Watchman would be a very good option. To get the Watchman procedure, your CHA2DS2-VASc score has to be 3. So in order to be a candidate, you have to be either over 75 and have hypertension, or you add up the points, but you need 3 of those points to have the Watchman procedure paid for. In general, some people will do the AFib ablation and the Watchman at the same time. I think our general approach would be to stagger them, get the AFib ablation, get through the healing phase, and then sometimes 3 months or later after the ablation, get the Watchman put in as a separate procedure. Increasingly, both of these procedures are performed as an outpatient.
Next question, do you know of any research to support if plant-based diet reduce or eliminate AFib?
I'm aware of no data on exactly what your diet consists of. There's huge data saying a low-calorie diet, that gets you to be really slim, reduces your chance of getting AFib. But whether you're skinny because you only eat plants or you only eat tiny amounts of meat, I don't think makes a big difference. It's really all about the calories, your body mass index, and so forth. But there may be some data, but I've never heard of any, and I'm not aware of it.
Okay, the next question is, for an early diagnosis, how long is optimal for blood thinners?
For an early, once you get diagnosed with atrial fibrillation, the next thing is, what is your stroke risk profile? And again, if it's elevated, if your CHA2DS2-VASc score is 2 or higher, certainly if it's 3 or higher, generally you should be on a blood thinner for the rest of your life, even if you had just a single episode of atrial fibrillation. There's going to be a study done fairly soon looking at what's called pill in the pocket anticoagulation, where they're going to take patients who have AFib and randomize them to being on the blood thinner all the time, like the current guidelines suggest, versus only being on it when you have an episode of AFib detected on your Apple Watch, like 2-3 weeks either side of that episode. So we'll have those answers in 5 years, but right now, we follow the recommendations that if your stroke risk is elevated and you've had even 1 episode of AFib, you're on blood thinners for the rest of your life.
Thank you. And Dr. Hopkins, can you just go to the next slide, please, as well? Thank you, I appreciate it. The next question is, does atrial fibrillation cause congestive heart failure, or does congestive heart failure cause atrial fibrillation?
Yeah, it's the old donkey and the cart situation. And the answer is both, that AFib increases your chance of getting heart failure. Certainly if you have AFib and you have a very rapid heart rate over 100, 110, 120 for 3 weeks or longer, that can put anyone into heart failure. Even if you have AFib where your heart rate's in the right zone, that increases your chance of getting heart failure. And then conversely, anyone with heart failure has a higher risk of developing AFib than someone without heart failure. So it goes both ways. AFib can cause heart failure, and heart failure can cause AFib. Heart failure caused by AFib is generally pretty easy to treat. You get rid of the AFib, or you slow the AFib down, and the heart failure recovers fully. Whereas obviously heart failure that causes AFib, you treat the AFib and the heart failure won't get any better necessarily, but you'll probably feel better.
Okay, next question is, when is AV node ablation procedure indicated or recommended?
And the AV node ablation procedure is sort of a bailout last ditch approach. So in general, when I see patients, we try to get them back to sinus rhythm with catheter ablation or medications. If we can't, then we just try to control their heart rate where their resting heart rate's 80 or less. If we can't achieve that with medicines they can tolerate, that's where we think about the AV node ablation, particularly if they're 70 or 75 or older in age. So someone who's 80 who has AFib, the heart rate in AFib is 110. We put them on medicines, we can't slow it down, they don't like taking the medications. That would be a great candidate for an AV node ablation, assuming we've tried to get them back to normal rhythm and that's failed. On the other hand, if someone's heart rate is 70 beats a minute on a low dose of beta blocker, even if you can't get them back to normal rhythm, I think it's preferable to leave that person in AFib than to ablate their AV node, make them pacemaker dependent, and put hardware in their heart.
Another question is, can atrial fibrillation be a late consequence of COVID?
Yeah, so absolutely, COVID has been shown to trigger atrial fibrillation. It's generally severe COVID. So if you have severe COVID where you're in the hospital on a ventilator and sick as can be, guess what? Your chance of having AFib go shooting up, considerably as well. Is it the stress? Is it the inflammation associated with COVID? It's a lot of different factors, but yes, absolutely, COVID can cause AFib. I don't think mild COVID, if you have sort of standard COVID, you've been vaccinated, I don't think AFib is likely to be triggered by that. But the sicker you are from COVID, the more likely you are to get AFib.
Okay, the next question is, I have a wet age-related macular degeneration. Will taking a blood thinner create more problems with excessive bleeding from blood vessels behind the macula?
Not that I'm aware of. I don't think that, I've never heard of that as a concern, but I'd have you ask your ophthalmologist, obviously.
Okay, for the next question, for patients who are of normal weight, normal blood pressure, and heart rate, are there any specific rate control drugs that do not lower heart rate and BP?
Well, digoxin doesn't affect blood pressure, so that would just have an effect on heart rate, but it's a fairly poor rate control medication. But I think the only one that doesn't, calcium channel blockers lower blood pressure, beta blockers lower blood pressure, not much. So it's rarely an issue. If it is an issue, that would be a situation you could use digoxin, but I almost never see that. It's very rare to have a patient with AFib to have a low normal blood pressure. Most patients with AFib have hypertension or high normal blood pressure.
Thank you. Another participant asked, I just read about a shortage of scan dye. Will this impact the ability to do ablations?
No, I mean, yes, there's a shortage, but certainly we haven't had any problems. There's two ways you need dye during an AFib ablation. One is we typically get a CT scan before the procedure to make sure there's no blood clots in your heart and to define your anatomy. That takes some contrast. So that's one. So we do use dye for the procedure. We also do what's called venograms when we do the procedure. So we squirt dye in your heart. We don't use a lot of contrast. And we certainly haven't been shut down. We do between 800 and 1,000 of these procedures at Hopkins each year, and so far there's been no slowdown because of the dye issue. But good question.
And another participant asked, I'm a 67-year-old female. According to the CHAD score that you shared, my score is 2. I had one episode of Fib lasting 3 hours 2 years ago. I'm on Eliquis. Would you continue me on Eliquis?
So this is an interesting question. So officially your CHADS VASC 2 for hypertension, for being you're 67 and being a woman, I think those were the two risk factors you mentioned, which would be a CHADS VASC score of 2. Current guidelines say if you're 3 or more and you're a woman is when you need to be anticoagulated. For a score of 2, it's optional. And in optional patients, it really comes down to how much AFib are they having, how big is their atrium, and what is their patient preference. So if you are having no AFib, you only had one episode 3 years ago, your atrium's small, and you don't like the idea of being on a blood thinner, you're someone where I would be very comfortable having you stop it until until AFib started to show up again. If, on the other hand, your mother died of a stroke and you're deathly afraid of a stroke and you don't want to take any chance of having a stroke, I would stay on the blood thinner like you're doing.
Okay, the next question, can gastric problems trigger AFib?
Well, gastric problems can cause stress, and stress can cause AFib, or gastric problems can interrupt sleep, and interrupted sleep can cause AFib. So I would say yes, but indirectly. One thing I want to make clear is that there's no data that coffee triggers AFib. So people commonly say, oh, you have AFib, no alcohol, no coffee. Well, the coffee is fine. It's really the alcohol that's the bigger concern.
Thank you. Another participant, you didn't mention surgical options for AFib. Can you talk briefly about them?
Yeah, so another option is surgical ablation. In general, surgical AFib ablation is usually done at a time you're having some other cardiac surgery done. So if you have to get your mitral valve replaced, your aortic valve replaced, or a bypass surgery, if the surgeon's in there anyhow, they can address the atrial fibrillation with surgical approaches. There's another approach called hybrid surgical ablation, or minimally invasive surgical ablation, where they go in only to treat the AFib using a port access sort of minimally invasive surgical approach. That's generally only considered in patients that have failed catheter ablation, one or two or three catheter ablation procedures before having that procedure. Even though a surgeon considers it minimally invasive, it's really not too minimally invasive. And there's also very few surgeons around the nation skilled at doing that procedure. So if you're at a center where you have a superstar surgeon who's great at doing the procedure, it's very reasonable to do, particularly if you failed one or maybe two AFib ablation procedures. If you're at a center that doesn't have any surgeon with skill doing that technique, it obviously doesn't make sense to do it. There's a new procedure called the convergent procedure you may have heard about. This is a procedure where the surgeon will do a minimally invasive approach and ablate the back wall of the atrium. And then the EP doctor will then ablate the endocardial side 6 weeks later or at the same time. So it's a hybrid procedure where you have both the electrophysiologist and the surgeons working together. That procedure was shown to be very effective for very refractory, what's called long-standing persistent AFib, lasting more than 12 months or longer. And the outcomes were 20% better than with just catheter ablation alone. So if you've been in AFib for 3 years and you're at a hospital where they offer that procedure, that's a very good option to consider. It's called the convergent procedure, and it's FDA approved with a very impressive clinical trial. And unlike a standard minimally invasive AFib surgical procedure that's super technically challenging, and maybe there's a handful of surgeons in the country that do it, there's many more surgeons that are skilled at doing the conversion procedure, which is much quicker recovery, much easier to do, and less involved.
Thank you. The next question, are there any specific triggers that cause AFib, like having a huge meal or too much sugar?
So the triggers for AFib differ in different patients. One trigger that some people describe is a really cold drink of water or cold beer or whatever. Turns out if you drink something very cold, that will cool the back of your esophagus, runs behind your heart, and cooling your heart will change the electrical properties. And for some people, that's what does it. So if you just give up the cold beverages, the cold ice cream, the slushies, your AFib will be gone. Other people, the trigger is alcohol. Cut the alcohol down, the AFib goes away. Other individuals, it's exercise. If they stop exercising, the AFib goes away. Others, it's stress or poor sleep. So different patients have different triggers, but generally, it's usually not enough to try to get rid of the trigger. That generally doesn't get rid of the AFib. I had one patient that concluded it was the stress related to work, so he quit working. And so then he is unemployed, and guess what? He still has AFib. So I generally don't recommend patients resign from their position and hope that their AFib goes away. I think that's pretty unlikely.
Thank you. And what about alternative medicines such as Reiki, massages, vitamins, etc.?
Things that lower your stress level can be effective in helping control AFib. There's been studies looking at yoga and deep breathing and things like that. The other alternative therapies I'm not very in tune with, and I think there's very little data to support them of being of value.
Okay, and what could have caused AFib while getting a colonoscopy?
Well, it may be I mean, AFib can happen at any point. Getting a colonoscopy is one point where I mean, it's a statistical thing, so it could show up having anything done or doing anything. I don't think there's anything about a colonoscopy that causes AFib. I have lots of patients that were diagnosed with AFib when they showed up for their colonoscopy, but I can't recall a patient that had AFib triggered by a colonoscopy. Now, I've only been doing this 30 years, but I think that's pretty uncommon, but I'm sure it occurs in some patients, but I think it's hard to blame the colonoscopy. That's not your way out of skipping your next colonoscopy. I don't think that's a very good excuse.
Thank you. Another patient. I have a short AFib episodes, about 10 minutes or less, 2 times a month on average. They always occur in the morning. Could this be related to sleep?
Oh, I mean, they may be related. I mean, I presume, you're in the early stages. In the early stages of AFib, I mean, right now you have a very low AFib burden. 10 minutes twice a month is not much AFib, and there's probably no real need to do anything about it at this point, other than consider your anticoagulation situation. But over the next 5 to 10 to 15, 20 years, it's likely to get worse. In terms of what's causing it, if you're sleeping poorly, that may be playing a role. If you're under a lot of stress, that may be playing a role. If you're doing a lot of drinking every night, that may cause AFib the next morning. So there's many different triggers, but I suspect you're over 50 and you're just starting to show the early phases of AFib sneaking in.
The next question, if on an antiarrhythmic like amiodarone prior to an ablation procedure, will you have to stop taking it before the surgery can take place?
That's a very good question, and there's very strong opinions on either side of the argument. We at Hopkins generally keep the antiarrhythmic medication going because your risk of having a stroke at the time of the procedure is less if you show up in normal rhythm. Other centers feel strongly that all the antiarrhythmics need to be out of your system because they look for something called non-pulmonary vein triggers. We don't consider that to be an important part of the procedure and generally continue antiarrhythmics during and for the first month or two after the procedure to help you get through the healing phase.
The next question, if a 20 milligram of Xarelto is tough to take, can you reduce the dose successfully?
You can reduce the dose, but you won't. I mean, you can take 2 10 milligram tablets. I don't know what the difference is in the size, but you can't, if you drop the dose down and use half dose, you aren't going to get the stroke prevention benefit of full dose. Lots of patients, it turns out, drop their anticoagulant dose, Eliquis from 5 to 2.5 twice a day, Xarelto from 10 once a day from 20 once a day, which is the recommended dose, to 10 once a day. And that's, it's done very commonly, but you have to realize there's no data that you're being protected from stroke at those low doses. It's not recommended. It happens commonly, but we strongly discourage it. And if the Xarelto pills are too big, then I'd look and see how big the Eliquis pills are. They're probably smaller.
Yeah, how much of this atrial fibrillation information can be translated to a flutter?
Oh, AFib and A-flutter, they basically run together. That patients with A-flutter is triggered by atrial fibrillation. So in order to get A-flutter, you need a burst of atrial fibrillation. So once you get rid of the flutter with a flutter ablation, which is typically a fairly simple outpatient procedure, if you look out 5 years, 50% of the patients will show up clearly having AFib. So, they sort of travel together. They have the same risk factors. The anticoagulation recommendations are the same. The big difference is that typical atrial flutter is a very small, simple ablation procedure with almost no risk, very uninvolved, very straightforward. But just because you get rid of flutter doesn't mean you can stop the blood thinner, and you got to be on the lookout because there's a good chance AFib will show up within 5 years after the A-flutter showed up.
Thank you. And the final question of the evening will be, are there cases of AFib being triggered by the COVID vaccine?
Oh, I've certainly heard of patients that blame it on the COVID vaccine. They have the vaccine and then they get AFib and then they blame it on the COVID vaccine. But the temporal relationship does not mean causality. I certainly wouldn't discourage people from getting the vaccine because they're afraid it's going to cause AFib. I think in some people, they have AFib, they get the vaccine, or maybe the stress they're getting the vaccine may uncover AFib that was sort of dormant or whatever. So clearly it's happened, but I don't think it's causative, and it's certainly not a reason not to get the vaccination. I think you're much more likely to die of COVID than you are from preventing AFib.
Wonderful. Well, this will conclude the webinar, this evening's webinar. We'd like to thank Dr. Hopkins for taking the time to present to all of us. And we'd like to thank everyone for joining us this evening. A recording will be emailed to everybody in the next day or so. And if you're interested in scheduling an appointment, please feel free to give us a call on the number on your screen or email us at hopkinsseminars@jhmi.edu. Thank you all for attending and have a wonderful evening.
Thank you. Have a good night.